Topic of the lecture today is Vibrio cholera. Now, first of all, whenever you hear the name Vibrio cholera, what should come to your mind? Vibrio cholera is actually a bacteria, an anaerobic facultative bacteria. What does that term mean? Anaerobic facultative bacteria, meaning that it can prosper in any environment. It can go with respiratory and it can do fermentation too. So it has high prevalence inside your body once it gets to your body. And basically, it's a gram negative bacteria and it's rod shaped. And in some cases, it seems like it's also found in a comma shaped. As I'll show you a diagram of it. This is an organism. This is the Vibrio cholera. Now you can see it's a comma shaped organism, and whenever you heat it up, whenever you put it under some specific conditions, it will go into a rod form. And what you see right here is a flagellum. That's how it moves. It contains one of it at the back end of its body, and this is what helps it to move inside your lumens, to move inside your body, to move inside your intestine. So it's a gram-negative organism, and Vibrio cholera has been known to cause epidemics. When this organism was not found, no one knew what happens when a person develops acute gastroenteritis. A patient developed acute gastroenteritis, the patient will go into dehydration, but the people didn't know what to do, how to compete with this organism, how to combat this organism. So what happened? They went into dehydration, then further complications happened, and the people died. One of US presidents and one of French presidents died because of acute gastroenteritis. Now that will tell you how severe it will get on you if you don't treat it in time. Many epidemics, many endemics have happened because of this Vibrio cholera. And now you don't hear of this kind of incidents that a person died because of acute gastroenteritis, because now we have improved sanitary conditions. Now we have improved sewage systems. Because the prevalence, the etiology of Vibrio cholera is that it will get to you through fecal-oral route. And how does that happen? It will happen when your water supply is contaminated or your food supply is contaminated. You must be thinking how food supply is going to be contaminated by the feces. Okay, let me tell you. Your sewage system is not good. It's draining into a freshwater pool or pond or whatever, and there are fish. Might be they'll go and eat on it. And when they do, and you catch that fish, you cook that fish, and it's not properly cooked, you're going to get it. Or what other method is there? The other method is after any bowel movement, you don't clean your hand. You're not doing those sanitary guidelines. You're not following them. You're not washing your hands after the bowel movements. After you went for evacuation. So these are the two conditions which will directly involve Vibrio cholera to your food. But there are multiple cases or multiple incidences of fresh water. You drink fresh water, it's not good. It's taken from a place which was contaminated with Vibrio cholera. You're going to get this disease. You're going to get this pathology. So what happens is that most of the cases, Vibrio cholera happens because of what? Water. Next, what's the second basic cause of Vibrio cholera getting inside your body? That's your food. And what's the third? Person to person. Now, this is very rare incidents, so we don't take much notice of it, but it can also happen in some cases. So these are three methods, the modes of the transmission of this bacteria. Now, this does not cause any kind of pathology in another organism which ingest it. Maybe the fish, nothing will happen to the fish. But the basic host it targets is human. And that's where its pathology lies. So now you know the mode of transmissions. Now you know what this bacteria is. It's a gram-negative bacteria. It's a comma-shaped bacteria. And it's basically found in two colors. Either it's red color, either it's pink kind of reddish shade. So this is how it's found. When there were endemics and epidemics happening, what happened? A scientist went on, and after the patient died because of this pathology, the scientist went on and performed the biopsies of that patient. He opened up that patient, he took the lumen of the patient, and he observed this organism. And he directly related it to this disease. But later it was found in 1860s, 1870s by Koch that yes, it's a direct affiliation to this organism that causes acute gastroenteritis. And once we know the organism, then we go for its antibiotics, then we go for its treatment options. So once we found this organism, we were able to harvest antibiotics against it. We were able to contemplate with its provocative actions, and that's how we started to manage it. But we have to know what's the pathogenesis of it. How does it go inside your body? What does it do? Why there's so much dehydration occurring? Why there's so much rice stools happening? So we'll talk about that. Worldwide distribution means that among the whole countries of the world, which countries got more cases of acute gastroenteritis in the observed years. Now this is a sketch of different countries which got this disease or didn't get this disease, didn't get this pathology between 2010 to 2012 per 100,000 inhabitants. Now, there are multiple countries you will see which have no reported cases at all. They're pitch green. These are the countries which got no reported case of acute gastroenteritis or cholera. Not a single case. Because of what? They had better sanitary conditions, they used clean water, and they adapted to better sanitary conditions. They used their hands after they went to the washroom and all of that. They followed through all of those guidelines and they eliminated this disease from their region. Now, after that, we have some regions which have 0.1 to 1 cases, right? And in this category, what falls? Our country, right? Our country falls between this and this, 1 to 10 and 0.1 to 1. Different countries have different prevalences here, right? So there are some countries which got 1 to 10 cases. There are some countries which got 10 to 100 cases. And there are some countries which got 100,000 cases. And those countries which got more than 1,000 cases are highlighted with the red marks, right? Now these red marks mean what? That they are getting thousands and thousands of people are getting this disease. Because of what? Unsanitary conditions. Because of what? Unclean, unhealthy water. Because of what? Because of all of those factors which facilitate this disease, which facilitate the spread of this disease. Now, most of the African countries, the Northern American countries, and some Asian countries, you will see in this map, you will find this red and this orange in only African countries, Asian countries, and North American countries. Why? Because they don't follow through these sanitary guidelines. They don't get clean water. They don't go for sanitary habits. That's why they're getting this disease again and again. And when one person gets it, what happens then? The other person is going to get it because it's contagious. It's contagious because that person is going to get it. Maybe most of the cases, your family members are going to get it. Or those people who consume that water in which your feces are going, in which your feces are being drained out. That's why it's contagious. And in these developing countries, we don't have any methods of cleaning water. We don't do proper sanitary inspections. That's why we get this disease more often than European countries. Next on, let's talk about the pathogenesis. Now, pathogenesis means that this organism got into your body. We talked about it, it's going to be fecal-oral, it's going to be oral. It's not going to get into your skin. It's not going to get from anywhere else. It's not going to be inhaled, it's going to be ingested. And ingested how? How are we going to ingest it? The water, we talked about it. The water is the basic causative environment that we're getting it from, right? So when we consume water, which was inhabiting these bacteria, or we consume that food which somehow got in contact with that bacteria, or somehow, somewhere, we got it and we ingested it. When we ingest it, what happens? It goes down your esophagus. And when it reaches the stomach, it stops. It goes dormant. It stops the production of its proteins. Why does it stop the production of proteins? Because at that time, it knows that it has to reserve right now because of the acidic environment of stomach. And these organisms propagate and survive in alkaline environments. So to survive that acidic environment and to just go through that area, they go dormant. They don't propagate. They don't create their proteins. They don't provide their proteins. What happens afterwards? They go through the stomach and get to the small intestine. Now that's where the pathology starts. That's where it happens. So this is a sketch of your small intestine, a small part of your small intestine. Now this is proximal bile coming in, right? Proximal bile is coming in, and this is distal bicarbonate, right? Now this is your small intestine. What happens is that these bacteria are coming in, right? They're coming in, they're diving into what? Your mucus. Because your small intestine is lined with mucous membrane, right? So it's not going to affect mucus. What it's going to affect? It's going to affect the lumen. So it crosses the mucus, it gets to your lumens. See, this is the lumen, this is the muscle layer. It crosses the lumen, it gets to your muscle layer and causes what? Causes all of those pathologies which will lead to acute gastroenteritis, dehydration, and other complications. Now, this is initial colonization. They came out from the stomach, they propagated, they dived into your lumen, they got into your muscle layer, they're affecting the villi of your small intestine. Now what? Now they're colonizing right there. They are propagating, they're colonizing. And when they colonize, they'll jump onto the next location and they will keep causing this pathology all over your intestine. So, in initial colonization, it comes in, it dives in, it propagates, it produces more of its bacteria to infect more surface of your intestine, and then it will propagate. Now, next on, dissemination and excretion. It will go on and go on and go on until it's excreted from your feces. When it's excreted, that's how it propagates. That's where the next contagious stage of the disease comes in. It goes to your drains, it goes to your water supply somehow. If it's not being cleaned properly, if it's not being protected, if your natural water reservoirs are subjected to your fecal contamination somehow, they'll get there. Some other person will drink that water, some other person will get this disease. That's how they propagate. That's how these endemics and epidemics happened. So afterwards, at the F stage, it gets disseminated, it gets excreted, it goes to your water supply somehow if it's not being protected and gets to the other person. That's how they get into your body, they use your body, they cause this pathology and then get excreted and then cause this pathology, cause this disease in another person. That's their mode of action. That's how they propagate. Now let's talk about the pathogenesis of what's happening in that small intestine. We talked about they come into the small intestine, they colonize there, they cause this pathology, then they get excreted. But what about what's happening in that small intestine that caused your gastroenteritis? What happened in the small intestine that lowered your immunity? What happens in that intestine that it sometimes people get rice stools? What's the pathology that's going on inside a small intestine? Now let's talk about that. So first of all, this is a Vibrio cholera. We talked about it's comma shaped and sometimes it's rod shaped. Now you can see it's capsule rod shaped and it has its flagellum right back. And what happened? They came from the stomach right here. Let's assume stomach is right here. It came from your stomach, and what happened? They got to your small intestine. They dived in. Now they're very motile because of their flagellum. Now they're very motile. So what happens? They dive into the mucus, that mucus lining, that mucus membrane which is lining the small intestine. They're going to dive in. They're going to get to the villi. They're going to infect those spaces. What happens? As you can see, this Vibrio cholera came in. Now they are getting there, right? And they're colonizing there. They're getting more and more of them are affecting more and more surface area of small intestine. Now this, what is CTXA? CTXA actually, what Vibrio cholera produces different kind of toxins, different strains of it, from 01 to I guess 0136. So different kind of pathologies happen at every strain, with every strain. So these are the strains, these are the genetic makeups, you can say, which produce these protein, which produce these toxins. There are two types, CTXA or CTXB. It's either type A, it's either type B, right? So what happens is that they are going to affect what? They're going to affect your uh, G protein. They're going to affect your G protein how? They get attached to your G protein, and what happens next? When they get attached to your G protein, a cycle of things start which will lead to activation of what? GS subunit of G protein, which will be activated. How does that happen? When it gets attached to it, GM1 will give a message to what? Endosomes. Proteins will be produced and they will go to endoplasmic reticulum. From there, it will go to ARF6. And afterward, what happens? Now, what is ARF6? Let me tell you, it's adenosine producing factors, right? Adenylyl cycline producing factors. So what happens? They go into this Golgi apparatus and they get proteinated. And what happens next? They are going to activate what? They're going to activate adenylate cyclase. When adenylate cyclase is activated, what happens then? Now, this adenylate cyclase is not activated temporarily, it's activated permanently. That's why it's labeled in the red right here. It's activated permanently until this infection is there. So, when it's permanently activated, why it's permanently activated? Because all of this reaction is happening again and again and continuously it's happening. So, your adenylate cyclase is activated now. What happens if it's activated? Cyclic adenosine monophosphate will be increased, right? CAMP will be increased. Now, if CAMP is increased, what happens then? It leads to certain kind of reaction, certain kind of happenings inside of your membranes. It opens certain channels and it closes certain channels, right? PK, this CAMP, increased CAMP levels will affect the PKA and CFTR. And what happens next? Certain channels will be opened. What certain channels? Chloride channels will be opened. These chloride channels will go right into your lumen, right into the your small intestine. And what happens next? Negativity is increasing. So, what will follow through? Sodium, potassium, and bicarbonate will follow through. And when they will follow through, what comes next? Water will come in. That's why a huge amount of water will be coming out of it. Because this reaction, this chloride, this hyperchloridemia is going to attract more and more water, more and more HCO3, more and more potassium, more and more sodium. So you're getting 4 hypoconditions in this pathology. What hypoconditions? Hypochloremia, right? Bicarbonate levels are going to go down, potassium levels are going to go down, sodium levels are going to go down, and water levels are going to go down. And which of them is the most notorious one? I'll say all of them, because all of them have different impacts on your body. When we'll talk about the complications of it, when we'll talk about the signs and symptoms of it, you'll know what sign came from what hypoconditions, what sign came from what depletion. Among these, what depletion caused that sign and symptom, right? So, chloride will rush into your lumen, Chloride will rush through it, chloride will get to your small intestine, HCO3, potassium, and sodium will follow through. And where's this water coming from? Water is coming from the blood. So it's also causing what? It's going to cause hypotension. It's going to drain the blood of water. And where's that water going to go? It's going to go into your feces, it's going to get excreted. Now, continuously, this action is happening. Now, continuously, this pathology is happening. This pathology is occurring at a regular base. And what are the consequences of it? The consequences are water depletion, severe water depletion is happening, sodium depletion, potassium depletion, bicarbonate depletion, and chloride depletion. And all of these have very extravagant effects on your body, which we will talk about in sign and symptom. So that's what happens. That's why you get these voluminous discharges. That's why you get these feces which are watery in consistency, and you get it from the very start. You won't even feel any pain inside your body. You won't feel any pain inside your abdomen because it's just happening. It's just happening. It just started to happen. With time, what will happen? Pain will increase because you're losing water, you're losing everything. You're losing very important electrolytes of your body alongside water. You're going dehydrated and electrolyte imbalance is happening. And what happens? When a patient will present to you after like 2 to 3 hours that this is happening, you have to go immediately for all of these replenishments. Because first of all, you have to replenish all of these, then you'll start the treatment with antibiotics or whatever the mode of treatment you want to. But first of all, you have to address this problem. Now, the incubation period of Vibrio cholera, is between 2 to 5 days, right? But it can vary. That's what I'm trying to tell you. It can vary. You might be eating something, and after some hours, you get this pathology. You get this pain in your abdomen. You get this acute gastroenteritis. So it can vary, right? So it gets in your body, it causes all of these pathologies, and this will lead to acute gastroenteritis, voluminous excretions, and all of these signs and symptoms that we're going to talk about. All of these dehydration effects, the potassium depletion effects, the sodium depletion effects, the water depletion effects, and chloride depletion effects, we're going to talk about what those signs and symptoms might be. Now, this all will lead to diarrhea, right? Voluminous, watery, ricey stool diarrhea. Now, I keep saying the word ricey, ricey. So, how does it, come out as ricey? There's no rice in it, right? The point is, when Vibrio cholera gets to your lumen, before that, what does it invade? It invades your mucus layer, right? When it invades your mucus layer, it destroys it somehow, and sometimes, in some cases, not all of these cases, some patients get this ricey stool vibe because they think it's ricey stool, it looks like rice. No, it's not. It's actually mucus which came out with it, which got destroyed and came out with it, which got infected and then came out with it. That's why they're ricey stool. And that's why they're watery in consistency, because they contain most of the water of your body. Next on, let's talk about the clinical manifestations. What are going to be the general clinical manifestations of that patient? First of all, there will be sudden onset of painless watery diarrhea. I told you, first of all, there will be no pain. There will be just watery diarrhea, and you might be thinking, what did I eat wrong? Where did I go wrong? Then you'll be thinking, okay, I think it will pass away, but it won't. This diarrhea will quickly become voluminous. Now it will contain more and more volume of water, more and more volume of all of these things, more and more volume of your feces, and their occurrence, the intervals between them starts shortening. You'll go to the washroom like 3 to 4 times in 1 hour, and you can imagine how quickly you go dehydrated. And that's why Vibrio cholera has many strains. Some strains you'll get diarrhea, you won't even know that you have the diarrhea, you have this pathology inside your body. You won't even know, and it will get okay. But some strains which contains these toxins, right? These enterotoxins, they lead to severe pathology, and they lead to this diarrhea which will be voluminous. And next, what will happen? You'll get the vomiting. You'll get the vomiting because of irritation. You'll get the vomiting. You'll get the diarrhea. You'll get the dehydration. You'll go nauseated. All these symptoms will come in. Now, these are the general symptoms, right? Now, if volume loss is more than 250 milliliter per kg in first 24 hours, right? And we're talking about what volume loss? In the vomiting, volume loss must be more than 250 milliliter per kg in the first 24 hours. And then you'll start these muscle cramps because your muscles are also being affected. We talked about in the last slides that it gets to your muscles even. And what's the basic cause of muscle cramp? It's not because Vibrio cholera got there. No, Vibrio cholera are never going to go to your blood. They're going to just stay there and cause this pathology. What's the basic cause of muscle cramp? I'll give you a minute, just think about it. Muscle cramps are happening because of potassium depletion. We talked about it will be because of potassium depletion. We talked about how these electrolyte imbalances will affect the body. One of those effects is these muscle cramps, right? Now let's talk about the clinical manifestations regarding parallel volume contractions. So first of all, if loss of volume, percentage of body weight included, if it's less than 5%, only sign or symptom or clinical manifestation you're going to get is thirst. You'll feel thirsty. What if it's between 5 to 10%? You'll get postural hypotension. Why? Because of severe dehydration which is happening inside your body. Because your volume of blood is going down. It's getting thicker and the volume of the blood is going down. You're going into hypotension. Next on, you'll go weak because of dehydration, because of severe electrolyte imbalances, you'll go weak. Next one, you'll have this tachycardia because what? Your volume of the blood is now low. Your blood pressure is down. How will the heart compensate? It will go into tachycardia to compensate all of these phenomena. Next one, we have decreased skin turgor. Because of dehydration, you will get decreased skin turgor. And where will you check it? You will have these sunken eyes. The patients who come to you and are dehydrated, you'll just have a look at them and you'll know this patient is dehydrated because they have sunken eyes. They have dry tongue. Right? Next one, if it's more than 10%, you're going to oliguria. What is oliguria? Oliguria means decreased urine. Decreased urine, why? Because all of that water supply is going somewhere else. All of that water is being excreted somewhere else. Next one, you'll go weak or absent pulses. Why? Because of severe dehydration, the content of water inside the blood has gone to zeros, and the quality of blood has gone down. Maybe it will go into absent pulses. Maybe the heart won't be even working anymore after so much of tachycardia, after so much of postural hypertension, after so much of hypertension. The BP, the blood pressure will drop, and you will go into absent pulse. Next one, the sunken eyes. We talked about it's a sign of severe dehydration. You have wrinkled skin because the skin tone will go down because there's no water in it to tone it up. Next on, you have somnolence, and then you can go into coma even. Why will you go into coma? Because severe electrolyte imbalance, because heart is not working fine, because of all of these hypoconditions that are happening, and you are excreting so much of volume which you're not even ingesting, and the body will just collapse. The body will just go into coma. The blood supplies will be compromised. The electrolyte imbalances will be compromised, and this will lead to comatose patient. Next on, let's talk about the clinical manifestations regarding cholera gravis. Right? Now, this is a patient which is suffering from cholera gravis. You'll just take a look at it and you will know that this patient is suffering from cholera gravis. Why? You can see the sunken eyes, you can see the helplessness on the face, you can see the skin tone is down, skin turgor is down, severely dehydrated patient, you'll know it's because of Vibrio cholera. Next on, let's talk about the diagnosis. How will you diagnose it? But before we go on to the diagnosis, let me tell you some basic manifestations of different electrolytes that we lost. When sodium and chloride are lost, what happens? Brain function will go down. When potassium is lost, what will happen? Maybe electrical imbalance inside the heart. Heart activity will be compromised because of electrolyte imbalance in the heart. Potassium is not there. Right? Next on, it can have effects on your muscles. You'll go into cramps because potassium is not there. You're having these imbalances of electrolytes. That's why you will have all of these clinical manifestations along with these general manifestations that we talked about. These are general manifestations. Then we have specific manifestations regarding every hypocondition that we're going to face in this patient. Right? So, what laboratory findings that you'll go for? What will you go for immediately? First of all, you will have to go for the CP. What CP? Complete picture of the blood. It will tell you what hemoglobin of the patient is. It will tell you what hematocrit of the patient is. And hematocrit of the patient will be higher because of this destruction that is happening inside the RBCs. Next on, you have mild neutrophilic leukocytosis. You will have mild neutrophilic leukocytosis. Neutrophil will be mildly increased in their normal quantity inside the blood. Next on, you'll increase blood urea nitrogen because you're having oliguria. You're not excreting enough urea. You're not excreting enough nitrogen levels. So they are building up inside your body, and increased blood urea nitrogen is there not only because of oliguria but also because of water content of the blood is so down that blood is now concentrated and that urea concentration has risen above its normal level. Next on, you'll go for the creatinine, you'll go for the bicarbonate levels. Now bicarbonate levels will be down because we are losing bicarbonates. We're losing HCO3 in the urine, a lot of it. So bicarbonate levels will be down, and then you will have elevated anion gap. What is elevated anion gap? It's a difference between different electrolytes. It's a difference between electrolyte balances, and it has to be very narrow. It has to be very fixed. And what happens if one of those electrolyte or one family of those electrolytes are going to get excreted? The balance or that gap, that balance between that gap is going to get disturbed, and the gap between those anions are going to increase. The elevated anion gap will come in. Next on, you will have arterial pH as low as of 7.2. Right? Now 7.2 is what? An acidic pH. So you are having this low arterial pH when this patient is in severe dehydration, when the patient is suffering from this pathology. So all of these will be the findings if you just go for what? If you just go for the blood testing. You don't do anything else. You just go for the blood testing and you will find all of these things. Now this is what you'll look for in blood pictures. Next on, what will you do? You have these blood tests there, it's there, but what other methods are there to confirm your diagnosis? You'll go for the conventional methods in which you'll ask the patient to get it isolated and identified of Vibrio cholerae bacterium. How will you do that? You'll ask the patient to give you a sample of its feces. Then the laboratory takes it, the culture is done, and after the culture is performed, the culture is done, and on the microscope you see it's Vibrio cholerae, then you're sure that it's because of this pathology is because of Vibrio cholerae. Next on, you'll go for different biochemical tests in which you will perform different cultures, in which you will perform different kind of growth methods, and you will get to the diagnosis eventually. Then you'll go for serological testing that will also help you in reaching the definitive diagnosis. Next on, what are the current technologies that are available to us in diagnosing the patient these days? You can go for cholera toxin detection assay these days. You can go for DNA probes and PCR. You can go for lateral flow dipstick assay, and you can go for loop mediated isothermal amplification assay, and then you can go for biosensors. Now, all of these are current technologies. These are advanced technologies. Now, all of these technologies are not present in every developing countries. That's why they go for the complete blood picture. That's why they go for cultures, because they don't have all of these modalities available to them. They don't have all of these technologies available to them. But in the developed countries, they have these technologies in which they can just detect the cholera in the assay, in which they can go for the DNA probes and PCR and get it amplified and then look for it and find Vibrio cholera there. Or they have even dipsticks in which they can confirm its assay, and we don't, obviously developing countries don't have that technology up till now. So in bigger cities, in the developing countries, maybe in bigger cities, yes, there might be one or two places available, but it's not enough, because this kind of pathology needs all of these current technologies at every doorstep, at every place, so that people can go for easier technologies, people can go for easier detection methods and start the treatment as soon as possible, because it takes a lot of days to get the culture results back. So that's why they go for these speedy methods, they go for these current technologies, and then they have these biosensors available for it. They can go for loop mediated isothermal amplification assay too. Now, these are the current technologies that are available. It's not like they're available everywhere, but the places where it's available, it's very easy, rather very easy to diagnose the patient at the early stage. Next on, let's talk about the treatment options we have now. What kind of treatment options we might have in the case of acute gastroenteritis or diarrhea or all of these pathologies that are happening? What's the treatment option? I told you that whenever you'll think of treatment, that okay, I have to treat one of these patients, you'll go for what? First of all, you have to replenish those electrolytes. First of all, you have to replenish that water content inside your body for even drugs to act better way, for even drugs to perform well inside your body, right? So first of all, you go for what? You go for water. You go for water. You have to give that person water. Otherwise, what will happen? The blood quantity will be so down that it will go into hypovolemic shock. And if the patient goes into hypovolemic shock, what happens? Fluid resuscitation and management will come in. You will calculate that how much fluid is required for that person. What parameters are required to assess how much fluid that person needs? His height, his weight, right? And you will assess the dehydration status, and that will give you a gist of how much fluid that person needs. So you'll go for the fluid resuscitation and management. Next on, when the patient gets back to its conscious level, when the patient can ingest something, you'll give that person ORS, right? It's oral rehydration solution. It does not only have water, it contains all of those electrolytes that we missed on, all of those electrolytes that were excreted, and we need them right away. Otherwise, the complications of those different electrolytes will come in. So before that happens, you have to go for oral rehydration in which those electrolytes are present, and that's how those electrolytes will get replenished. Next on, we have Ringer's lactate with additional potassium supplements. In the Ringer lactate, we have some electrolytes already present, and then we add potassium into it because hypokalemia is definitely going to happen, and it has a worst kind of effect. It has a worst kind of outcomes. So you give the patient Ringer lactate. If the patient cannot have oral ingestion, you give the patient Ringer lactate with additional potassium supplements. But if the patient can take ORS, you might want to skip this part. But if it's severely dehydrated, you have to go for the Ringer lactate. You have to go for the Ringer lactate and give ORS along with it. Next on, you have to use an antibiotic. Now that you have replenished all that water supply, now that you have replenished those electrolytes, now go for the antibiotic. Now the patient is out of danger. The patient cannot have any complication because of dehydration. The patient cannot have any complication because of hypokalemia. The patient cannot have any complication because of low levels of bicarbonate inside your body. The patient cannot have any complication because of that acidic blood pH, right? So all of those complications are now settled. They're not into the play. Now you have to treat that infection. Now that your body is back into the form, now you have to get that Vibrio cholera out of your body, and then you use antibiotic. Now, what antibiotics will be used? Let me ask you that. That depends upon your culture. That depends upon the results of the culture. When the culture will come out and they will tell you that this organism is there, you go for the specific antibiotics which are used to target the strains of that organism. But how will we assess the dehydration status? I just told you some points of it, that how will we assess the dehydration status. But first of all, we have to talk about the degree of dehydration will be either none or mild, but diarrhea is there. Patient presents to you that I've been having diarrhea for 3 hours, but I've been taking ORS along with it. I've been taking a lot of water. I've been consuming a lot of water, so I'm not dehydrated, but I'm having this diarrhea. So what do? You do nothing in particular. That patient will be presenting to you with what? Thirst. And you'll do what? You will give the patient ORS and then you'll prescribe the patient antibiotics. And that's all. On the other hand, if the dehydration is mild, and when the mild dehydration is, when will you say the patient is mild dehydration? The patient will have thirst, the patient will have postural hypotension, the patient will have weakness, the patient will have tachycardia, the patient will have decreased skin turgor, and the patient will have dry mouth and dry tongue. Now, these are all the symptoms of dehydration. But at moderate levels, these symptoms will be found. So you'll know that it's moderate dehydration, and you'll go for the treatment accordingly, right? Next on, we have severe dehydration. And the symptoms will be patient will be unconscious. The patient can be lethargic. The patient can be in floppiness. The patient can be weak or absent pulses. Now, in these conditions, you definitely and immediately go for the IV line. You give the patient ringer lactate. You calculate the amount of fluids that person need. You give the person IV fluids. You give the patient oral fluids until the patient gets back his consciousness, and then you can start the treatment of antibiotics. And in severe dehydration, the patient will come to you with floppiness and unconsciousness. They won't be able to even drink water anymore. So you have to be very careful while making them ingest water, because they can even choke on it. And you have to start with maintaining an IV line. And the patient will have sunken eyes. We talked about that. It's also another sign of what? Dehydration. Now, we talked about that we'll give the patient ORS in moderate condition. We'll give the patient ORS in mild conditions of dehydration. So what is ORS? We talked about it contains different electrolytes. It contains water content. Well, what electrolytes? First of all, we have sodium in it, which is 75 millimole per liter. We have potassium in it in the concentration of 20 millimole per liter. We have chloride in it, which in the concentration of 65 millimole per liter. We have citrate in it in the concentration of 10 millimole per liter. And we have glucose in it in the concentration of 75 millimole per liter to give that person some energy, because that person is drained, that person is weak, that person has gone into hypoglycemia. So you can see the potassium concentration in the ringer lactate is down. It's not that much. It's not going to be enough. It's not going to be enough. That's why we add more potassium to it. We talked about in the last slides that we give ORS with additional supplements of potassium. That's why we give it, because it contains only 20 millimole per liter. It can also, so the total osmolarity of this fluid is going to be 245 millimole per liter. Next on, let's talk about the treatment options in the form of antibiotics. Now that we have managed, now that we know how to manage the dehydration status, now that we know how to manage the electrolyte imbalances, and now that they are being treated, now that they're being addressed, now you have to address this infection. Now you have to get this Vibrio cholera out of your body. And what will help you with that? Antibiotics will come in. And what antibiotics have proven to be of more effective value in this condition of Vibrio cholera or in the pathology of cholera. Erythromycin, azithromycin, tetracyclines, doxycyclines, and ciprofloxacin. Now, these are the groups of drugs which are very helpful in eradicating this pathology. Now, all of these have different outcomes regarding different strains. So, first of all, you go for the culture. The culture results are back that okay, it's because of this organism, this strain. Then you go and target that specific organism, that specific strain with these antibiotics, and all of them have different kind of range for different strains, for different organisms. So you look at the culture report, you look at the patient, and you give the antibiotics according to the severity of the disease, according to the culture reports, and most of all, according to the sensitivity of the patient to these drugs. So you prescribe the antibiotics for a specific dose for a specific time until that infection is no more. And you counsel them that even if you get better after taking these antibiotics for 2 days, you have to take them for 4 days, because you have to, because in some cases Vibrio cholera is still there, infectivity goes down, and the patient thinks that he's fine, and he stops taking these antibiotics, and then the infection propagates again. The infection comes in again, and this acute diarrhea will come in again. So that's why they have to complete their course so that it can be eradicated completely. And along with the treatment, what can we tell them? What can we tell them about their future modalities of life? We can tell them how to prevent this disease, right? First of all, we'll tell them to wash hands properly. Whenever they go to the washroom, we'll tell them to drink safe water, use safe water even for the bathing or whatever. Even if they are going to take a bath, they have to use the clean water, because some of it goes to your mouth and people do ingest it somewhere or somehow. And you have to use clean water for the drinking purposes. Next on, we'll tell them eat well-cooked food. I told you an example of the fish. That fish might have this organism inside of it, and if it's not properly cooked, you're going to get it. So you have to eat well-cooked meats, well-cooked foods. Next, we have to clean our kitchen and washroom properly, because these two are very contagious places, and a lot of people can get this organism from these places if they are not cleaning the washroom properly, or if they're not cleaning the kitchen properly. Next on, you can get vaccinated for it. Now the vaccines are available for this pathology, so they can go and get vaccinated so that they don't get this pathology again, right? Next on, we have these non-cholera vibriosis. I told you it's not about that Vibrio cholera is only one and it's only going to cause this acute gastroenteritis and this diarrhea. No, it has different types. These organisms depend upon it. First of all, we have Vibrio parahemolyticus. It causes gastroenteritis, it causes wound infection. On the other hand, we have non-01 by 0139 Vibrio cholera. Right? I told you different strains. It causes gastroenteritis, it causes wound infection, it also causes otitis media. Next on, we have Vibrio vulnificus. Vibrio vulnificus causes sepsis, it can cause secondary cellulitis, it can cause wound infection, and it can also cause cellulitis. So it has nothing to do with causing diarrhea or with causing acute gastroenteritis. So it causes all of these pathologies. On the other hand, we have Vibrio alginolyticus, which causes wound infection, which causes cellulitis. Now, as you can see, different forms cause different kind of pathology. It's not like all of them are going to cause gastroenteritis. Maybe it's Vibrio vulnificus and it causes sepsis, and it's much more dangerous. It causes cellulitis, it causes wound infection. So, or it can be alginolyticus, which causes only wound infection and cellulitis. Or it's these two forms and they can cause gastroenteritis. So it totally depends upon the organism. And it also, Vibrio alginolyticus also causes otitis sepsis. I separated it from the rest so that I can tell you that only two of these organisms can involve your ear. So that will help you in your differential diagnosis, that if there's a scenario and it tells you that, okay, it has gastroenteritis, but also the patient has this otitis media or otitis or ear pain or something like that, that would be a hint for you to pick up that it's between these two. It's either non-0139 Vibrio cholera or Vibrio alginolyticus. Then you will confirm it by checking for gastroenteritis. If the patient is suffering from gastroenteritis, it's this form. If it's not, and if it's only cellulitis or wound infection, then it's because of Vibrio alginolyticus. So that's all for Vibrio cholera. That's all you have to remember for Vibrio cholera, that what is this organism? What's the microbiology of it? It's gram negative. We talked about it. It's comma shaped. It's red and pink in color. And how it's going to get inside your body. Those three modes of transmissions we talked about, you have to remember them. Then there's this pathogenesis, that how it gets to your body, how it hijacks your system, how it causes increased levels of CAMP. Then your G protein, S unit of your G protein gets activated, and all of that pathology we talked about, that it's going to colonize there, it's going to propagate there, get excreted, and then the next person who will consume those products is going to get this disease. Next time we talked about the different modalities we'll use to diagnose this patient. We'll talk about how we're going to get to our definite diagnosis. Then we talked about what current technologies are, which are not available in some part of the world, but available in most part of the world. We talked about how they are very easy to get to a definite diagnosis and go on from there to the treatment. Then we talked about the treatment options. We talked about that this pathology leads to various problems, including dehydration and electrolyte imbalances. First of all, you have to correct them. If the patient is conscious, you have to give them ORS. If the patient is not conscious, you have to maintain an IV line with ringer lactate. If the patient is conscious and still it's severely dehydrated, you go for the ringer lactate along with ORS. You decide on the condition of the patient. Next time we talked about, then we'll go for the antibiotics. We'll choose the antibiotic regarding and on the results of your culture, on the results of your history, and on the examination, you'll decide which antibiotic is suitable for this person, and whether this person is resistant to this antibiotic or sensitive to this antibiotic or allergic to this antibiotic or not. After doing all of that, you have to tell them some modalities that they have to adapt to, that they have to clean their hands, they have to keep sanitary conditions, they have to clean their washroom, their kitchens, they can get vaccinated. You have to counsel them regarding the preventary methods so that they don't get this pathology again, so that they don't suffer from this pathology again. And next on, we talked about the different kind of Vibrio cholera, different kind of organisms which are in the form of, in the species of Vibrio cholera, these vibriosis. They cause different kind of pathologies. Not all of them are going to cause gastroenteritis. Maybe some of them are going to cause cellulitis. Maybe some of them cause ear pathologies, cause otitis sepsis. Maybe some cause secondary cellulitis. So the outcome of these Vibrio's infections is going to be totally dependent upon which organism is causing this pathology, and the pathogenesis and the pathological consequences totally depend on that organism. So that's all for today. Thank you for watching sqadia.com.